Hello. I'm going to spend a few minutes discussing why many providers are hesitant to prescribe opiate or narcotic pain medications for chronic long-term pain. And if not opiate pain medications, then what medications do work? As part of the team at the Montana Spine and Pain Center, I can help optimize your pain medications. With your help, we can evaluate whether your current medications are working or not or causing any side effects. If you don't know if a medication is still helpful, we can discuss whether it needs to be tapered down slowly or if it can be abruptly stopped. Then we can determine if it was helping or not or causing any side effects. We can also discuss the medications you've tried in the past to see if there are any potential ones that have not been tried or which were not given an adequate trial. Whenever possible, I like to recommend the fewest number of medications. Sometimes one medication can treat more than one problem, such as pain and difficulty sleeping. If you would like to come off your opioid pain medications, I can make a recommendation back to your prescriber on how to taper off them to avoid withdrawal symptoms. Tapering too fast can cause rebound pain among other symptoms, which then makes it seem like they were working better than they actually were. So my job is to help optimize your pain management medications. Most people, when they think of pain medications, think of the opiates or narcotics. Opiate pain medications can be very effective in the short term, such as after surgery. Can you imagine going through surgery and not having an opiate pain medication? They can also be effective during active cancer treatment and at the end of life. These medications in the short term can improve function, decrease pain, and overall improve quality of life. Unfortunately, they have not been shown to be effective long term for persistent or chronic pain. They appear to do the opposite over time. Patients who are started on them initially report improved function. However, over time, they do not report lower pain scores and actually report decreased function. Long-term, opiate pain medications have an increased risk of surgical complications, interfere with physical rehabilitation, and delay wound healing. Whenever one considers taking a medication, one should balance the possible benefit or effectiveness with the possible side effects. Each person has different side effect potential, depending on things such as age, kidney function, liver function, and other diseases. It makes no sense to take a medication that has little possible benefit or effectiveness and a very high risk of serious side effects. We now know that the opiates are associated with much more serious side effects and are much more dangerous than we previously thought. The most serious side effect is death. I got into pain management back in the 70s because we were underusing these medications for the treatment of surgical, trauma pain, cancer pain, and the pain and suffering at the end of life. Because these medications work so well in the short term, they started being prescribed for all kinds of persistent pain that people live with for a long time. I like this graph because it goes back to the 1970s when I first started practicing. As opiate medications began to be more widely prescribed for all kinds of pain and suffering, the number of opiate-related deaths increased. This graph shows that the deaths from prescription opiate pain medications continue to rise. In 2015, 16,000 people died. That's 43 people per day, which means that every 30 minutes or so, someone dies from an opiate-related overdose. This is a serious public health issue. This is an interesting graph. The blue dotted line shows that the number of deaths from motor vehicle accidents decreased from 1979 until 2013. As you can see, the death rate decreases over time. As cars get safer, more people wear seatbelts, drunk driver laws get stricter, etc. As opposed to the bottom line, which shows the increasing rate of accidental prescription drug overdoses. As you can see, more people die from accidental prescription overdoses than from car wrecks. As I said, this is a huge and preventable public health problem. How do opiates cause death? Opiates are powerful central nervous system depressants. They rewire the brain to think that you do not need to breathe. If one stops breathing, then the heart stops. How does accidental overdose happen? Well, what happens when something was working for a while and then it does not work as well? Some people take more, or they have underlying breathing problems such as emphysema, COPD, or sleep apnea. Other people might combine it with other central nervous system depressants, such as alcohol, skeletal muscle relaxants, or benzodiazepines such as Valium, Xanax, Ativan, etc. Benzodiazepines and opiates are a particularly dangerous combination. Hyperalgesia is defined by an increase in pain. This develops in about 25% of people who take opiates on a long-term basis. They actually develop an increase in pain which is the opposite of what these medications were supposed to do. Normal sensation can be felt as pain with this condition. The only way to treat it is to taper off the opiates. These drugs can also cause a lot of changes in our normal hormones such as testosterone, estrogen, growth hormone, adrenaline, insulin. This rewiring of our neuroendocrine system doesn't happen in a couple days, but can occur over several months. It is sort of a sneaky, slow thing. We have our own natural opiate-like substances, endorphins and enkephalins, that our body stops making when we take it in from the outside. As you can imagine, this could be part of the reason why hypersensitivity develops and withdrawal symptoms occur if opiates are abruptly stopped. We know that testosterone will return to baseline about 2 months after opiates are stopped. About 25% of the population has the genetics to be at risk for addiction or substance abuse. Addiction generally occurs in the picture of having first the genetics to put one at risk, access to the drugs such as getting it prescribed after surgery, and then overlaid with stressors such as financial or family stresses. If you think about what drives dose increases in addicts, it is to get the drug high or euphoria that occurs for some with these drugs. However, addicts keep needing to take a higher dose to get the same drug high. Most chronic pain patients do not identify with the words euphoria or drug high. What they identify with is that they feel normal when they take the opiate medication, and they do not feel normal when they don't take it. That is a mood change. Tolerance develops very quickly to mood changes and drives the need to increase the dose to get the same relief every 3 to 9 months. We can't keep chasing mood with opiates. We also know that anxiety and depression get worse when people are on opiates, and they get better when people get off opiates. Physical withdrawal is not addiction. Physical withdrawal can occur when opiate drugs are abruptly stopped. Withdrawal symptoms can be severe, like the worst case of flu ever, or I feel like I'm going to die. Severe nausea, vomiting, diarrhea, heart palpitations, sweating, chills, insomnia, anxiety, etc. can occur. Mild withdrawal, which can happen in between doses of short-acting opiates, can be simply felt as increased anxiety and increased pain, making it feel like when one takes another dose that it is really working, when instead it's just stopping the mild withdrawal. Here's the most astonishing and exciting fact. We've tapered hundreds of people off opiates, and what's surprising is that most people say that they feel overall better, either with no increase in pain despite being off their medication, or even that they have less pain than they did before. We wouldn't have believed it if we hadn't seen it over and over again. So because we are committed to helping you be more functional in the long term, we will not prescribe opiates if you're not currently taking them. If you're currently taking them, it is likely that we will recommend that you taper off. Keep in mind that this is based on science and our own experience with patients over the last several decades. There is no long-term effectiveness of opiates in terms of reduced pain, increased function, or improved quality of life, and there are very significant scary side effects. This is a picture of our spinal cord. When we have an injury, picture stubbing your toe, a nerve signal is sent from the toe to the spinal cord. At the spinal cord, there are multiple different chemicals that get involved in whether that nerve impulse continues up to the brain or not. The brain has a responsibility to figure out what that nerve signal means. Is it saying that the toe is cold, or itching, or in danger? It is the brain that determines what it means and what should be done about it. Pain is a protective feeling produced by the brain, and then we protect the injured part until it heals. The brain and immune system also learn and remember all past danger to warn us sooner the next time, so we don't keep repeating things that injure us. Once we are healed, though, the protective feelings are supposed to stop. The brain has the ability to send a message back down to the spinal cord that says, "Calm down, I'm healing, I'm getting better." There is no need to keep sending these danger signals. In persistent pain, the nerve endings don't get the message to calm down. Too many signals are coming through at too high an intensity. Something in the nervous system is out of adjustment. The first-line medications that are effective for persistent pain are the anti-seizure medications and certain antidepressants. One does not develop tolerance to them with respect to pain. The anticonvulsant medications, such as gabapentin or Neurontin, and pregabalin or Lyrica, and several others, are shown to decrease the signals going into and produced by the brain. And certain antidepressants, not all of them, have pain-relieving ability even in patients who are not depressed. The most common are duloxetine or Cymbalta, venlafaxine or Effexor, amitriptyline, and nortriptyline. These improve the dampening signal from the brain to the spinal cord and help it say, calm down, stop sending so many alarming pain messages. I've been a pharmacist for a long time. In the world of persistent pain, it seems that while medications can be helpful for some, they are a little disappointing. In studies, medications on average will reduce pain by about 30%. If you are living with pain 10 out of 10, 30% may not be enough to make the pain tolerable. So what does work better for persistent pain? The good news is that lifestyle changes and the neurobehavioral approaches, such as education and movement that we teach here, have been shown to have better outcomes than medications alone for most persistent pain. And one doesn't get tolerant to them or need a hand-signed prescription. Please listen to our other short videos for more information regarding the most successful treatments for persistent pain that do result in decreased pain, improved function, and overall better quality of life.